Hi there, and welcome to a new episode of Clinical AI Academy Rounds. The goal of Clinical AI Academy is to improve AI literacy in healthcare. A recent longitudinal study of 370 medical students found that active AI use, especially when supervised, was associated with improved AI literacy and, in turn, stronger critical thinking skills. So today we have a clinical case involving an AI-assisted diagnosis, and we will discuss how clinicians should respond when AI gets it wrong. The case: a 24-year-old tall, thin male smoker presented to the emergency department with sudden left-sided pleuritic chest pain and mild dyspnea. He was stable, with oxygen saturation of 97% on room air. An erect PA chest radiograph was processed by the AI screening tool, which did not flag pneumothorax. The junior resident in the ER that day, unfamiliar with the limitations of AI triage systems, too busy with other cases, and since the AI was never wrong as far as he was a resident, interpreted the negative AI result as reassurance rather than decision support. Without even looking at the X-ray image independently or escalating the image for senior review, he diagnosed musculoskeletal chest pain and discharged the patient with oral analgesia. At home, the patient continued smoking, went to work as usual as a construction worker because he had been told the pain was just muscular. Over the next several hours, the chest pain intensified and his shortness of breath worsened. His colleagues brought him back to the emergency department, this time tachypneic, anxious, and hypoxic. Repeat imaging showed progression of the left pneumothorax with mediastinal shift, now larger than on the initial film. The supervising clinician reviewed both radiographs with the resident. On the first image, a subtle left apical visceral pleural line with absent peripheral lung markings was visible, measuring less than 3 centimeters from the apex, consistent with a small left apical pneumothorax. The AI tool had produced a false negative result, but the clinical presentation had been highly compatible with pneumothorax. The supervisor corrected the decision-making process. The AI output should have been treated as one data point, not as a rule-out test. The resident should have performed a systematic image review, reconciled the AI result with the clinical picture, and sought senior input before discharge. How would you have approached this case? Let me know in the comments. Thanks, and see you in the next round.